Every year, thousands across the Indian subcontinent die from an emergency that progresses in minutes. A snake bite delivers a complex, liquid toxin directly into the vascular network, creating an acute physiological crisis that demands immediate pharmacological intervention. The vast majority of these fatal envenomations come from 4 specific snake species, a group collectively known as the Big Four. And finally, the saw-scaled viper is uniquely recognized by a pale, wavy pattern along its flanks and its aggressive, coiled posture. Knowing these visual markers is useful in theory, but relying on them in an emergency room is a dangerous clinical trap. Patients rarely bring the snake, and waiting for visual confirmation wastes the golden hour of treatment. To save the patient, clinicians must treat the symptoms, not the snake. To treat those symptoms, you have to understand exactly what the venom is doing. The assault happens on 2 distinct microscopic tracks. The first is driven by the neurotoxic venoms of the cobra and the krait. These toxins target the neuromuscular junction. They physically bind to and block the acetylcholine receptors on the muscle fibers. The brain sends the signal to breathe, but the signal never arrives, causing a rapid descending paralysis. The second track is the henotoxic and cytotoxic assault delivered by the vipers, which targets the blood and local tissue. Viper venom causes consumptive coagulopathy. Its enzymes enter the bloodstream and systematically shred floating fibrinogen molecules. Without fibrinogen, the blood completely loses its ability to clot. Simultaneously, the venom exerts a secondary cytotoxic effect. It breaks down the cell walls at the site of the bite, causing severe tissue necrosis and agonizing local pain. Because these venoms attack such specific biological targets, they create predictable patterns of failure. A clinician can diagnose the exact class of venom solely by watching the patient's physiology collapse. That collapse is often accelerated by the panicked actions taken at the bite site. In the chaos of the moment, the human instinct is to aggressively intervene, slashing the wound, attempting oral suction, or tying off the limb. Tying a tourniquet is particularly dangerous. By completely halting arterial and venous blood flow, a tourniquet traps the highly destructive cytotoxic venom in a confined anatomical space. With the venom localized, it rapidly digests the surrounding cells. This accelerates compartment syndrome, destroys the vascular supply, and guarantees ischemia and gangrene in the affected limb. The only evidence-based pre-hospital intervention is the RIGHT protocol. Reassure the patient, immobilize the limb, go to the hospital, and tell the doctor the symptoms. Immobilization in this context means treating the bite exactly like a fractured bone. Applying a rigid splint slows the lymphatic drainage, which is how the venom primarily travels, without occluding arterial blood flow. In snakebite management, traditional trauma instincts kill tissue. The only valid first aid is keeping the limb viable and rushing the patient to a facility equipped for definitive pharmacological care. Once the patient arrives, the clinical trigger for administering antivenom relies entirely on the syndromic approach. We do not treat based on bite marks. We look for the presence of 3 specific physiological failure syndromes. The first syndrome is severe local envenomation. This presents as rapidly progressive swelling that crosses a joint, usually accompanied by painful, tender regional lymph nodes. The second is neurotoxicity. We look for the clinical signs of descending paralysis. This almost always begins with ptosis or drooping eyelids, followed by double vision, a broken neck sign where the patient cannot hold their head up, and ultimately respiratory failure. The third syndrome is hemotoxicity. It is indicated by spontaneous bleeding, like a nosebleed or blood in the urine, or a systemic failure to clot. To test that clotting ability, we use the 20-minute whole blood clotting test. It is a definitive, low-tech diagnostic. You draw fresh venous blood, place it in a clean, dry glass tube, not plastic, and leave it undisturbed for exactly 20 minutes. After 20 minutes, you tilt the glass tube to 45 degrees. Normal blood will have formed a solid clot. If the blood remains liquid and runs down the side of the glass, the patient has consumptive coagulopathy. The presence of any single one of these 3 syndromes confirms systemic envenomation. At that moment, the protocol immediately shifts from clinical observation to aggressive chemical neutralization. In the Indian subcontinent, the definitive countermeasure is polyvalent anti-snake venom, or ASV. ASV dosing is strict mathematics. Each milliliter of reconstituted ASV is engineered to neutralize exactly 0.6 milligrams of Russell's viper or cobra venom and 0.4 milligrams of kite or saw-scaled viper venom. This leads to what looks like a dosing paradox. A small child receives the exact same initial dose of ASV as a fully grown adult. This bar chart illustrates why patient weight is irrelevant. An average Russell's viper injects roughly 67 milligrams of venom in a single bite. Because a single 10 milliliter vial neutralizes 6 milligrams, we need at least 10 vials to neutralize the first 60 milligrams of that venom. If a snake injects its maximum lethal payload of 143 milligrams, neutralizing it will require between 25 and 30 vials, regardless of the patient's size. Administering this much foreign serum carries the risk of anaphylaxis, leading to a persistent myth that clinicians should administer a small test dose first. But the hypersensitivity reaction to ASV is primarily complement-mediated, not strictly IgE-mediated. A small test dose will not trigger the complement cascade, making it completely useless for predicting anaphylaxis. You only lose critical time. ASV administration is a rigid neutralization equation, where time equals tissue. Delaying the initial dose to run a useless test violates the core principles of emergency toxicology. After that initial 10-vial push, the protocol demands reassessment. You repeat the 20-minute clotting test every 6 hours. If the blood still fails to clot, you administer another 10 vials, up to a strict maximum of 30 vials. In neurotoxic cases, ASV is sometimes paired with neostigmine, an adjunct pharmacological therapy used to reverse paralysis. Neostigmine works with extreme anatomical specificity. It acts as an acetylcholine esterase inhibitor. It blocks the enzyme that cleans up acetylcholine, flooding the synaptic gap with neurotransmitters. This wave of acetylcholine outcompetes cobra toxins, restoring muscle function. However, neostigmine fails completely against kite venom. Kite toxins act presynaptically, destroying the acetylcholine vesicles. There is no neurotransmitter left to protect. Finally, for hemotoxic bites, clinicians must navigate the surgical limits of local necrosis. While severe swelling can mimic compartment syndrome, the absolute rule is that a fasciotomy must never be performed until the consumptive coagulopathy is fully corrected with ASV or blood products. Cutting into unclottable tissue is fatal. Managing snakebite envenomation requires abandoning generalized trauma instincts. It demands a precise, mathematically driven algorithm that directly targets the specific physiological failures induced by the venom.